I'm Luke Storey. For the past 22 years, I've been relentlessly committed to my deepest passion, designing the ultimate lifestyle based on the most powerful principles of spirituality, health, psychology, and personal development. The Life Stylist Podcast is a show dedicated to sharing my discoveries and the experts behind them with you. We're about to record a podcast with the brilliant Dr. Dwight Jennings, this guy right here, and he's an expert in jaw alignment. And that might not sound interesting, but once you hear how misalignment in your jaw wrecks your whole life, you're definitely going to be interested. So this is something I've been wanting to look into for a long time, and he's the man. We're up here in Oakland. I'm looking out at the bay. It's quite beautiful, and you're a fly on the wall, and you're going to watch this whole thing take place. After we do the exam and chat a little bit here, we're going to do a formal sit-down interview. If the camera's far enough away, you won't see inside my gross mouth. Don't worry. Okay, I'm ready.
Okay, check you out here.
Yes, sir.
So normally we would have a medical history. So we normally come in, do an intake, have a medical history, and then I get your chief complaint. Right, people have chief complaints why they show up here in the first place. And so between the chief complaint, we're integrating all that information between your medical history, your chief complaint, and the visual exam. So now we'll do a visual exam on you, and then we might talk a little bit more about cross-integration on other stuff.
Cool, sounds good. I also brought my night guard if it's useful.
Yeah, that would be probably worth looking at. There's lots of different beliefs and theories that dentists work on when they make night appliances, and then we can talk a little bit about what I think works and doesn't work.
Because regardless, I want to get a new one at least that goes on the bottom.
Yeah, bottom ones usually work better.
For starters.
The ones that I use for most of my patients fits both jaws simultaneously, but doesn't clip onto either jaw.
Oh, wow.
So it's what most dentists would understand to be a neutral bionator. So it has acrylic between the back teeth, but it indexes both jaws to a relaxed trajectory.
Oh, cool.
That is, it's people falling off trajectory that typically induces snoring, sleep apnea. And so you want to maintain them on that trajectory. You don't want them to displace when they go unconscious.
Got it. Cool, man.
Yeah, so let me just take a peek at you. Bite on your back teeth, close, hold it right there. So you have about 90% overbite. Upper teeth come down about 90% over your bottom teeth. And we look pretty well coordinated in the back. Open for me now. So what dentistry doesn't know is that when you're trying to figure out where a lower jaw needs to be, it's most important to look at where it goes when it opens, not where it goes when it closes.
Oh.
Because when it closes, we know it's dysfunctional. So the question is, where does it go when you open? And so most people that have retruded bites, as they open, their jaw drifts forward, and then as they close, it gets pulled back into the skull again. And so you're looking at where that forward position is that would normally close up. And a good way of doing that is just open wide for me and bite on my stick there, close. And one more time, open again and close again. So where your jaw goes when you bite on that stick is 95% accurate as to where the jaw needs to be. Normally, if you just stick anything between somebody's teeth, they'll normally close to that relaxed position. The brain instantly knows that they're not going to run into the front teeth, so they don't pull their jaw back anymore.
Ah.
For 95% of the population, where the jaw needs to be is tip to tip. So dentistry doesn't appreciate that there's biomechanical principles involved here. Muscles are strongest at their resting length. Muscles are like fibers, right? And they can either elongate those muscles or you can foreshorten those muscles. And if you do either of those two muscles, they get weaker. So muscles attach to your lower jaw to be strongest and most relaxed whenever they have to service the furthest point from your jaw joint, where they have the least biomechanical advantage, and that's when you bite tip to tip. So for the vast majority of people, when you're trying to find out where that lower jaw needs to be, it's always when they're end on end, which is how all primitive humans used to be.
Wow.
Right. There's
humans had it figured out.
Yeah, there's biomechanical reasons why we need to be there. And these days, when they're looking at integrating a lot of airway issues, again, that gives you maximum forward positioning of the jaw to give you maximum airway too. So it's to treating you to a tip-to-tip bite. And there's a good website, pgocclusion.com, maintained out of England, that gives a lot of evidence as to why a tip-to-tip bite is better.
Cool, and we'll put that in the show notes for those listening and watching,
Yeah.
so that you can find that.
So bite on your back teeth, close right there, and then slide your lower jaw forward out tip to tip. And bring your lower chin out. Yep, hold that right there, perfect. So now I'm going to look in the back. When you slide forward, you have kind of a mild defect in the back. Some people, depending on the steepness of their jaw angle, when they slide that jaw forward, it drops down a lot in the back, and they can end up with very large gaps back there. But in your case, you're down only about 2 millimeters, right? Which means your treatment, if you ever treat this, it's pretty easy.
I'm treating it.
Okay.
I already decided.
And so the other thing on you too, you're a little bit what we call division 2. The upper 2 front teeth are in just a little bit from the teeth beside them. And so there's a little bit of an overlap right here on this tooth and on this tooth. Your 2 front teeth are behind these teeth a little bit. And so it's not these teeth that are out of position, it's the 2 front teeth that are out of position. A lot of people think where this one, the second tooth over turns out on them, that's the defect, but it's actually the 2 front teeth that need to come forward. So getting those 2 front teeth forward will also allow you to get that lower jaw more forward.
I feel like they didn't used to be like that, and I swear, I think from wearing a night guard, it smushed my teeth tighter together like that.
Could.
Is that possible?
It's possible, because so that's a big problem in sleep apnea appliances. They bring those jaws forward, and I've seen multiple cases when they bring the jaws forward that over time they can't get the jaw to go back anymore. And so, like, I just had a gentleman come in, he'd been in a sleep apnea appliance for 12 years, and when he bit down, the only thing he touched was his front teeth. Right, he can't, his jaw just won't go back. The joint had got decompressed, the cartilage had reinflated, but you could do the reverse. You can, this is adaptable structure, and it could adapt to having, if you're getting pushed back every night, that you'd end up further back on you. That's the main reason that we put our finished cases in an end-on-end bite. We want to make sure that they stay there at nighttime, because if they fall out of that at nighttime, over time they will go back on, just as you're describing.
Right.
When those bites go off, not having molar support causes massive problems in the body. There's Japanese studies showing people missing their back molars when they bite down. On average, some cases were worse, on average it decreased brain blood flow by 40%. Right.
Whoa.
Right. Lack of molar support. Anytime, so the Japanese have done 40 years of research on bite destruction in animals, and anytime you shorten the molars on an animal on one side, it makes the opposite side of the body become hypertonic, tense, tighten up, and they all get scoliosis.
What the hell?
So not having.
When you say molars, does that mean wisdom teeth, or the ones further?
So there's 3 molars in the back: first molar, second molar, and wisdom teeth. They're
okay.
molars.
So I have all my molars, right?
Right.
So I'm missing a wisdom tooth upper left.
Right. Yep. You got all your molars, which is really good.
Oh, okay, good. Because there were times when various dentists wanted to pull them all out, and I was like, it hurts too bad. Let's leave them.
And so but it's part of the problem, so the adaptive process you're describing. So like my daughter was born with a severely retruded lower jaw to the point that she had a pretty significant speech defect. She kind of like they were from Boston when she was younger, right? But when you bring that, like I started treating her at age 3, and when you bring that lower jaw really far forward, bring it out of the socket ends up bending, remodeling, going back into the socket, and it ends up elongating the lower jaw. And so she's able to keep all of her wisdom teeth.
Oh, wow.
Right, but if you take somebody whose jaw is really far back and this whole thing's bent forward on them, it reduces the length of the lower jaw, and they're much more likely to have to need wisdom teeth removal.
Oh, interesting. So would you say in many cases you could avoid having to pull wisdom teeth by just properly aligning the jaw first?
At a young age, yes.
But you've got to do it young.
You got to do it young.
Yeah.
Mm-hmm. That recent book that was published a year ago, Jaws, The Story of a Hidden Epidemic, the orthodontist that co-wrote that, she won't treat anybody over age 12.
Wow.
Right, so she wants to be able to get a lot of growth potential.
Wow, crazy.
Yeah.
Cool.
But yeah, getting the jaw forward. So if you keep the jaw forward at nighttime, it wants to be more forward in the daytime. And so that's part of the problem with most or a lot of TMJ therapy, is they give you a mouthpiece that works great when you're upright and conscious, but when you go unconscious, the jaw displays on you. So they never quite get to your optimal forward position. So a lot of these cases end up with still a slight overbite that they're treating for TMJ case purposes or jaw orthopedic purposes, because they're falling back at nighttime. So if you support that jaw forward at nighttime, they'll want to be more forward in the daytime, and you can get them all the way out to where they maintain tip to tip.
Sweet.
Now the problem with treating somebody tip to tip, it demands a higher degree of precision in orthodontics. That is, it's extremely critical that when you bite down and hit those front teeth, that your back molars are slightly taller than your front teeth, right? What should happen on an ideal bite is that you close up and hit your back molars, and your jaw rotates, decompresses from your jaw joint, and touches your front teeth, right? But the brunt of the force is on the back molars. There should be no vibratory, percussatory pressure on your front teeth when you bite down. Right? You shouldn't. If you tap firmly, you shouldn't feel the front teeth vibrating. And so in our cases, when we treat them, we over-treat them slightly. We get those back teeth slightly too tall and let function bring them back together. So we want to make sure that they're hitting here, there's a little bit of space in front, and they decompress to get those front teeth together and get all the decompression out of the jaw joint cartilage. Dentistry doesn't really appreciate the fact that the cartilage within your TMJ joint is compressible and adaptable. And so they don't typically use it. So the entire treatment that we're doing on a TMJ case is with what they call pivoting mechanics, and that is the back molars are high and the front teeth are clear. And so you're always trying to jack those joints down, make the back teeth taller, getting the jaw to close up, pivot up, and get maximum decompression within the TMJ joint.
Hot damn.
If you have compression within the TMJ joint, it overworks your temporalis muscle. Right? This is the muscle that pulls your jaw up and back. Your temporalis muscle is tied in integratively, centrally with gallbladder. Right? So if you look at the gallbladder meridian, it Z's back and forth to your temporalis muscle. And so people that have the jaw back too far, temporalis overworked, are going to have a lot more propensity towards gallbladder dysfunction and gallbladder removal.
Wow, it's crazy how all that's related.
Yeah.
Well, we're definitely going to, when we sit down and do the official interview when I'm not in the chair, I want to get into that.
So let me check you one other way here.
Yeah.
Another way that we check, this is polyvinyl siloxane. It's silicone. It sets up in about 15-20 seconds.
Okay.
And it'll show me how all your back teeth fit together.
Oh, cool.
So this is something that general dentists should be doing on every patient, just to see how those back teeth are aligned. I'll squirt you here.
Okay.
So dentists, for the most part, when they're trying to get anything even, they use carbon paper. And I use this material. Bite on your back teeth, close all the way. This is probably 20-30 times more precise than carbon paper. You can hold it up to the light and it gives you a thickness on it. It's like a thickness gauge, pressure gauge, and it is just much more accurate at trying to get people precise. And this system here is sensitive enough that it needs that kind of precision. Yeah. Yep, that's good. Look, open up there. Good.
Wow, that sets so fast. That's crazy.
So when we hold this up to the light and look at it, so you're hitting heaviest on this tooth, not so heavy on those teeth, and your left side you're really not hitting properly.
I can feel that. Yeah.
Your left side's a little bit light. You're not really touching on the left side, and then you're hitting the front teeth too heavy too. You'd like to see this lighter on the front teeth. But we look at this for peaks and valleys. You're actually lined up quite well on your peaks and valleys. All those little holes in there are caused from grinding and teeth typically not being precisely lined up. Right. So that's as a form of compression erosion that happens on teeth. You get some up on these teeth too, right? But this most orthodontic post-treatment cases, if you look at them, these will be significantly off. Like on this side, on your left side, where that one tooth is touching, it's hitting just the outside slope of that tooth. When a tooth hits precisely the way that it should, there should be equal amount of light on this side and that side of this ridge, right?
Wow, that's such detail.
And so you can see that all the pressure's on that side and nothing on that side.
Right. That's funny because every time I've had adjustments done or any kind of fillings and they use that carbon paper, the inside feel never matches what they're telling me. The dentist, oh no, it's great, it's perfect, we got it. And I'm like, no, you don't. Like you just said, I already knew that the right side hits right there in the middle. I mean, I can just feel it.
See, they could never figure this out with carbon paper.
Right.
They could never.
Like I can feel that my left side doesn't touch. That's where I have an implant on the bottom. When the dentist put that in, God bless him, he's a great dentist, but he put that in. I'm like, dude, the bite's wrong. That tooth's not touching. And now we see that it's not.
Right.
God damn it.
but this is crucial, essential to doing this work precisely. You have to use this material.
Why do they use carbon paper still?
That's what they're taught in dental school.
Oh, wow.
Yeah, they just don't know. They just don't know.
Got it.
But doing this gives you a lot of information on somebody. Orthodontists need to use this on all their cases. They don't. They're just looking visually to see if you look good. And they assume that everything will line itself up, which isn't the case at all.
Clearly.
And so, this is a great tool for assessing bites. But because you can see the difference, the amount of light coming through here on the this is probably, you're talking 10,000ths of an inch difference on those sides, but it shows it up.
Right. So for those of you listening and not watching this on the YouTube video, he's now taken this gel that's firmed up from my bite, and it just looks like some blue chewed up gum in the shape of a U, and you can see the indentations of where the teeth are hitting. When he's talking about the light, it's just thinner at the places where the bite's hitting harder, and so it's just a really clear, obvious representation of what teeth are hitting and when they do, how much.
Right.
Yeah, that's cool.
Back molars are supposed to hang a half a tooth out over your bottom teeth. So the inside peak of your upper molars is supposed to hit the middle of your bottom teeth, and the outside peak of your lowers is supposed to hit like gears. And if you start touching on the slopes, then every time you bite down, the jaw shifts, and that puts a lot of stress on the musculature, the joint, the proprioceptors, sensors, and on your teeth too. When you hit a tooth on a side like that, it makes that tooth flex a little bit, and that'll cause notch and erosion and cervical recession on teeth. A lot of dentists think that recession on teeth is from toothbrushing too hard, but it's typically more often from those teeth not being precisely lined.
I've had dentists tell me it's from eating almonds. I'm like, really? I think my teeth are harder than an almond. Like, I don't eat that many almonds to begin with.
So when you're chewing, your teeth don't really come together, right? So food bolus in between there shouldn't make a difference.
Yeah, you have shock absorbers called food in there, right?
Right. Yeah.
Okay, noted. Do you want to look at my night guard?
Yeah, let's see your night guard.
Okay. This thing is disgusting, so I'm gonna hide it from the cameras because it's so gross. Every time I start dating someone, I'm like, I hide the night guard on the nightstands. It's so nasty. I don't care how many times, especially now because mine turned blue from my blue Canatine nootropic. All right, here it goes.
So bite closing up. So that's actually forcing your lower jaw further back into your skull.
Really?
Uh-huh. That's typically what an upper one will do. It's got a ramp on the back of those front teeth, and so when you hit it, it drives the jaw back.
I can feel that now that you say that.
Yeah. So historically, dentists were taught to push the jaws back, but nobody in a progressive mind these days wants that. They all want the jaws brought forward for airway purposes, for functional purposes. There's a huge controversy in dentistry over what causes TMJ. There's the psychosomatic school of thought, and they think it's too much stress, overwork in the system. But the two largest TMJ organizations in the United States believe that it's that the jaw is back too far, and that you have to structurally change that jaw. They do what they call anterior repositioning therapy, which is what I'd recommend to fix your case. You got to get that lower jaw forward, and to get it forward, you got to get the back teeth taller to keep it forward.
Can I take this out now?
Yeah, I think that. Yeah. Yeah. So that's.
So that thing sucks. I sense that. So, what can we do from this point to fix my bite and get me set up with a new night guard? What are the steps?
So you want to do look and see what you might have imaging wise. You'd like to see the image of those TMJ just as a baseline, see what kind of state they're in. Then from the imaging, you do moles of your teeth. We do a bite registration, and the bite registration, let me do that on you.
Okay.
So I'm going to squirt you and have you bite on my stick.
Okay.
So listen to me here.
Mm-hmm.
Squirting this material in, there's a little deprogramming. So I also see in your mouth that you have fairly large outgrowths of bone, what they call tori's.
Mm-hmm.
And tori's are bracing bone, so the bone thickens due to the stress on it. And bite on my stick there, smile, and slide your jaw forward for me, and back a little, right there. Maybe forward just a hair. Yep, right there. Perfect. And then we're going to see how easy you can find this bite once it sets up. Then we'll give you a temporary bite surface. And we're going to look at your arc of opening and closing. We do have abilities to do all this under computerized instrumentation also, which we do in some cases. But for the vast majority of people, getting them, just having them bite on the stick is quicker, faster, and cheaper than using all the fancy technology. Open for me there. So I'm looking at your jaw and bite close on that again. And one more time, open again, and bite close again. Yeah, so that's pretty good. You also have a slight midline discrepancy. The upper middle teeth don't quite match your nose. Yeah, you're off a little bit. And so that makes your lower midline not quite match your upper midline. Open again for me there. Yeah, that's tracking pretty good. But this gives you the gap in the back, and this is still with the stick in here. So this isn't a very large discrepancy in the molar area than what you find on some individuals.
So, rating from 1 to 10, 10 being the worst bite discrepancy, where would I fit based on this initial
Probably about a
analysis?
3.
So not that bad.
Not that bad.
Cool.
Yeah. So anytime you bring the lower jaw forward, it necessitates that you have to widen the upper jaw, so that you're bringing a widened part of your back molars into a skinnier part of your upper jaw. And so you want to, that's part of the process, is widening that upper jaw. So the appliances, the treatment is we put you into appliances. So I have an example of the appliances that we use. And I don't see those here. We'll have to do the interview and show you those. But
Okay.
but the appliances are used for the first phase, for the first month or two, to find out exactly where that jaw functionally wants to be in space. And once you get the jaw functionally aligned, then that dictates the orthodontic treatment that you need.
Oh, cool.
So phase 1 is to find out where it needs to be. Phase 2 is to stabilize it in that therapeutic position, ideal functional position. And phase 3 is to maintain it there over many years.
Cool.
Right.
So for right now, I just keep using my night guard, and then we just start doing the further evaluations and taking those steps that you just indicated.
Yes.
Cool.
Yeah.
Awesome, man.
And then the other thing that, so medical history-wise, is anything you want to bring up? And
Well, I think I've done a lot of work on the whole body here. Thank you, body. And I think the things that have been persistently difficult for me to overcome, and I have a lot of resources and knowledge and experts to see, such as people like you, have been digestive issues, gut issues, and also systemic migrating pain, like joint pain that just moves around, and then really long-term lower back and right hip pain.
Okay.
That I don't know, recently I had this transformative kind of healing just a few days ago that seems to be having a really positive effect on the hip and the back. But yeah, it's just like body pain and digestive issues. Other than that, like energy levels and all my labs and stuff are really good, but the gut's been a little challenging, I would say.
So with compromised bite relationships, it tends to push up your substance P levels in your body, and substance P is a major regulator of gut function. So what's supposed to happen is when a person chews, your substance P levels naturally and normally blip up, and that turns on gut motility to process the food that just went down there. But when there's constant bite dysfunction, it keeps your substance P levels high, and it makes you a lot more prone to constipation, diarrhea symptoms. Plus, what substance P does to the body is it creates a systemic whole body leaky gut phenomenon. it opens up cell membranes.
Whoa.
Right, and so substance P is a major regulator of leaky gut. Right?
Damn.
And as substance P goes up, it hypersensitizes the body, so people get overly reactive to all kinds of foods and stuff. So a lot of people, when they eat something and they have a reaction to it, they think that they can't tolerate that food, but it may be just that the process of chewing pushed up their substance P levels a little bit higher, and they get reactive to what went down there, regardless of what it was.
Oh, that's interesting.
Right.
Wow, what a trip. God, I bet so many people have been misdiagnosed with food intolerances and allergies and whatnot because of that.
Right. So substance P is what causes allergies. It causes Crohn. It's elevated in Crohn's, IBS. It's a primary driver in both of those conditions.
Wow, interesting.
Right.
Damn, this is good stuff.
Substance P, every cell in your body is like a little battery, and substance P attaches to those cell membranes and opens up that cell and lowers the voltage potential on cells. And so when cell voltage potential drops, then cells fire too easily. So like substance P is the primary mediator of seizures, right? Those cells then all fire too easily because the cell membranes drop. But it's also a major neural secretory modulator because secretory cells now secrete too easy. Right, so substance P throws off female hormones, throws off thyroid, throws off, all your endocrine system. Jaw dysfunction is a biomechanical stress on the body, and consequently, its primary impact is in the kidney. Right, as a stress organ, is your primary stress organ. So you see a lot of kidney dysfunction. There's lots of case histories about how bite dysfunction goes away with orthodontics on like bedwetting and other stuff like that.
Wow, man. God, dude, you've discovered the holy grail of mystery illness here. This is really, really cool.
But it's that depolarization, cell membrane integrity that contributes to a lot of illnesses. Substance P controls all skin disorders: eczema, seborrheic, psoriasis, acne. Right.
Who knew?
Right, so I don't think it's, how you hit on your last tooth in the back is more important than all the rest put together. And so I think when those 12-year molars come in, it's a major factor in why the acne and and skin conditions that you see heavily at that age.
Oh, interesting. So it's another part of the puberty process.
Right.
In addition to the cascade of hormone changes and all that.
I had I have a theory on autism, and that is that the mother has a bad bite, and that she gestates this baby for 9 months in an altered neurochemical environment, too much substance P. And the research shows that autistic babies, when they pop out of the womb, have too much substance P. And when the teeth start coming in on these children and they inherit the mother's bite, probably worse than the mother, then it is often what triggers them and puts them over the edge, and that's why you often see a delayed onset in autism. The primary pathology in autism these days is inflammation of the brain, which is primarily driven by substance P. And they have sensory disorders, they have gut issues, really, right? And if you look at the Porges vagal theory stuff, it's jaw proprioception is a massive input into that brainstem that alters social interaction.
Oh, damn.
Right. So.
Right, that makes a lot of sense. There's a lot of connections there. Wow.
Yeah.
Wow.
Yeah. So the polyvagal theory is missing the dental part of it. He didn't quite know the dental part of it.
Right.
But it's a major stimulant within the polyvagal theory.
Wow, that's incredible. My mind's blown. Well, I'd like to. We'll probably put out this part of the episode after the actual interview, but I feel like there's a lot of gold and rich information here I'd like to dig into. So, have you done whatever you need to do at this point in the mouth? Okay, so let's conclude the exam portion here. I'll make this a bonus mini episode, and then we'll sit down and really dive deep into some of the stuff you're discussing in the interview.
Sure.
So for those of you that are hearing this one second, know that we're going to repeat some of it because I want to go back and really dig in on some of this content.
That's good.
All right, thanks, Dave.